Right, apologies for absence. Wendy Becker and Munir Mohammed can't make it today. And any declarations of interest that aren't already declared? No. Well, I'm going to firstly welcome Julian Kelly, who's joined us. These are your first board meetings. So welcome to the NHS, Julian. And to thank Matt very much for standing in brilliantly for the last sort of 6 months. Is it 6 months? Yeah, so thank you, Matt. Yes, you've done a great job, so thank you very much. And Dido, you've got a couple of goodbyes to do as well.
Yes, you do the hellos, I do the goodbyes. Unfortunately, she hasn't been able to be with us, but this is Glynis Breakwell's last board meeting as a non-exec, so we wish her well, and we have a small thank you gift and a card that's circulating so that we can get that to her. It's also the last public board meeting for Stephen Hay and for Cathy McLean, who will be not leaving the organisation immediately, but reasonably soon, and I think we should mark both of you, not just your contribution to the boards of NHS Improvement, but to the NHS as a whole. You will be sorely missed when we actually let you go. But thank you very, very much. I wanted to put on the record, I'm sure the rest of the board would want to join me in thanking you and wishing you the very best in whatever you choose to do next.
Good, thank you. Minutes of the previous meeting, everyone happy with them? Any questions? And there are no matters arising. So we can approve the minutes. My report is one bit of formal business, which is to approve the recommendation from ARAC to approve the amendments to the standing orders and scheme of delegation ahead of the new operating model from April the 1st, 2019. I think that's just a standard thing to do. Simon, you've been through that already, and so can we just approve that? Excellent. So on my report, there's a couple of things I was going to mention. I've been to 3 new integrated sort of care systems, Cumbria, South Tyneside and Surrey. And all 3 are, doing some really good things. And what really struck me, that the basis of all of them was the relationships on the ground. If there are not good relationships, whatever we do centrally, whatever change in the law we do, it's just not going to work. There has got to be those sort of trusting, good relationships. And I thought in those 3 areas working really well. And the other thing I'd say is, because the CSUs haven't always had a great press, but I went to the northern CSU, NEX, and it was just fantastic. And we saw at a meeting earlier today some of the population health statistics and methodologies are being developed. I thought it was really first class, and I think Matthew and Emily, you've both been very much involved in that. I thought it was really fantastic. That was all I was going to say. But Dido, did you want to say anything before going to Simon?
I only had a couple of small things to say. The first one was just on my travels in the last month have been more workforce people plan focused. I've spoken and attended the CNO summit, been to a number of NHS provider meetings with a large number of chairs and chief executives, our own BME network gathering in Euston that David, you and I were at. And actually yesterday I was at a meeting with the armed forces looking at how we encourage more reservists in the NHS. And the reason I share all of those is there's an overwhelming theme, and Julian Hartley will talk a lot more about it, that is coming from everyone we talk to about how important it is to make the NHS a better place for people to work. That everyone I talk to is proud to work in the NHS but would like us to be a better employer. And a better employer that encourages diversity, flexibility and a modern sort of 21st century way of working. And in each of those sort of interactions I've had, it's been exactly the same thing. So that's been the theme of my month since the last last public board meeting. And very strong feedback from everyone out and about that means that we all need to change too. That as we mark, next week, the coming together, and I'm sure Simon will mention it, the formal beginning of our full joint endeavour between NHS England and NHS Improvement, how we use that as a moment to start to kickstart our own culture change. So that's my big theme. The other piece, just to put on the record, David, we had our second delivery, quality and performance committee this morning, full review of the operational quality and financial performance of the NHS as it stands today. Spent quite a long time this morning talking about how we develop the implementation plans for the long-term plan, a review in detail on the workforce planning and our own business plan for NHS England, NHS Improvement. And we'll publish the minutes in due course, but just wanted to put that on the record.
Okay, thanks, Dada. Simon.
Thank you. Well, first of all, just picking up where Dido left off, as she says, Monday marks the first of 3 sets of big changes across NHS England and NHS Improvement to bring the organisations together. A number of teams will be coming into new alignment as of the 1st of April. Then secondly, there will be a further set of changes around the summertime, and then thirdly, completing that in the autumn. So I just want to thank everybody across both NHS Improvement and NHS England who is going through this process. We will be making important steps as of Monday, the 1st of April, but I think we all recognise, the boards recognise that this is actually a process that is going to be taking 6 months or more, and we're immensely grateful for the ongoing support of all of our colleagues as we do that, and particularly the leadership that Ian is showing in the combining of a number of these roles over the next several months. Secondly, to say that it won't have escaped your notice that tomorrow is, of course, Friday, March 29th. We are been asked by the government now not to assume that Friday is the date on which we should entertain the no-deal contingency, but that has now moved to April 12th. It's not impossible that that date may move again, but the message both to people across the NHS and inside NHS England and NHS Improvement, again, is an enormous thank you for all of the work that's gone into contingency planning. Keith Willett and team, a lot of work across the health service. We're not out of the woods yet, so we're asking people to stay focused on that possibility with April 12th as the next nearest date. Thirdly, we are, as we discussed this morning, in the final stages of the 1920 operational planning and contracting round, and I think it's fair to say that an enormous amount of progress has been made even in the last fortnight, but there is a lot to get done between now and Easter, both in terms of syncing up the financial, the efficiency, the workforce and the activity plans so that we collectively go into the year with a viable set of operating plans across systems and institutions. And our new regional teams are going to be working very closely with system leaders on that. We're aiming to have a coherent total view for the NHS either by Easter or very shortly thereafter. So again, just for the board to note as we discussed this morning. And then lastly, there is in parallel with this an enormous amount of work going on now to co-design the long-term plan implementation framework, continuing the inclusive process we used in the LTP production itself, and the approach that has been taken in the workforce initial report. And I know, Dido, you're going to be talking about that later on with Julian this afternoon. But in addition to that, we are today identifying the founding members of the new NHS Assembly to be part of the guiding coalition in this inclusive way for LTP implementation. We are also on Tuesday afternoon going to be discussing with Parliament further details of the legislative proposals that were set out in the long-term plan. And then we aim in late April or May to publish the LTP implementation framework, which will then be working collectively across the health service and with our partners between now and the autumn to set out what that 5-year programme of change looks like in every part of the country. So those would be the 4 things really. Thanks to people inside the organisation, a reminder as to where we stand on Brexit, the 1920 operating plans and the LTP implementation. I think the rest we're going to be discussing during the course of the agenda.
Thanks, And Ian, have you got anything?
Just one item then in that context. I think just for the record, worth reporting that the formal merger of South Tyneside NHS Foundation Trust and City Hospital Sunderland NHS Foundation Trust has moved a step closer. Recommend both boards have applied to come together from the 1st of April, and acting as Chief Executive of Monitor, I have signed the dissolution order that dissolves those two trusts, and they then come together as the South Tyneside and Sunderland NHS Foundation Trust from the 1st of the 4th, 2019, a combined workforce of 8,000 staff, serving over 800,000 people across the northeast of England. So that's something for the record, I think.
Good, thank you. Good. Any questions for Simon and or Ian? Anyone like to raise anything? Nope. Okay, we'll crack straight on then. I think, Pauline, you're going to give us an update on... Where are you? Oh, there you are, Pauline. You seem like a long way away.
Yes, so the board, you have in front of you a report detailing performance for February, but I am going to bring you up to date. Clearly, some of the references that I make will be based on unpublished data, but it'll give you a sense of direction of where we are at the moment. I would like to start by thanking all of our staff throughout the NHS for the work that they have done during the winter period. All of our clinical staff, all of our managerial staff, people working at a local level, a regional level, and indeed a national level. And I think it's fair to say at this point that when the story of this winter is written, it'll demonstrate that the work that has been put in over the course of the last 12 months on the transformation front has really prepared us well for the winter period. And I think it will be the case that our performance this winter was better than last winter, and that's probably about the first time in 5 years that that has happened. But it's very much down to the commitment, dedication of everybody who really works within the NHS. At the moment, we are aware that we have seen within 4 hours about 380,000 more patients than during the same period last year. And that's against a background of having some increase in ambulance arrivals, some increase in attendances, and indeed in emergency admissions. But on the emergency admission front, I would also just like to draw people's attention to why some of that is happening. And again, it's around our transformation work, the increase in same-day emergency care, and those attendances, which we're very pleased about, because it's avoiding people having to stay in hospital overnight, but it's still coded in the data as normal admissions. When we look at our transformation work, we've seen an ongoing increase in the number of people telephoning 111 and using 111 online. The percentage for the winter period will be somewhere in the relation of about 12%, and over 50% of those people who've contacted 111 will have received clinical input during the course of that call. Last year, we were very concerned about the amount of time some of our ambulance handovers were taking when patients arrived at hospital. This winter, we've seen a very different picture. We have got a small number of organisations that continue to have problems, but overall, the amount of time people taking from the time they arrive at a hospital to being brought into the emergency department, etc., has improved enormously. And when we publish our data, we'll be able to give more information on that. As far as patients who are having long waits within the emergency department is concerned, we've seen a 30% decrease over the period. Again, because of the transformation work that we have done during the year, we have seen the results around the length of time people are spending in hospital. For 7 days, our percentage of patients who are staying more than 7 days, we've had an improvement of 7%, 21-day plus 11%, and an ongoing improvement on our detox metric. And during the last 4 months, we have seen a decrease in the number of operations that are cancelled. We talked at our previous meeting about the impact that flu was having this winter, and I think we discussed at that time the fact that the vaccine that we were using, the trivalent vaccine, was a very good match for the virus H1N1, and that the strain of the virus was a strain that was mainly affecting adults and younger people. But I think when we have reviewed all of our data for the period, it's important to note that the impact on our hospitals was still quite significant. During the whole of the winter period, the use of ITU, HTU beds was about the same as last winter, and during February, the use of all of our general adult beds was actually higher than the previous February. So it wasn't a case of the NHS did better as far as emergency care is concerned because flu wasn't the same burden. It was. It was much closer to last year than we had recognised, but I think what happened was that the hospital and the whole system coped better. As far as vaccination levels are concerned, one of the things that we worked on earlier in the year was to try and increase the uptake as far as staff are concerned, and there again we saw a better picture. 70.3% of our staff were vaccinated this winter against 68.7% the previous winter. So I think all told, the picture across emergency care demonstrates that the work that's been done on transformation is really starting to pay dividends. As far as being out there in our emergency departments at the front of our hospitals, staff are reporting and we are seeing far less congestion than in the previous year. And clearly from this point onwards and on an ongoing basis, our focus needs to continue to be on transformation. Within the long-term plan, the operating plan, etc., we have set out the importance of having even more same-day emergency care and really doing better as far as length of stay is concerned. We freed up about 2,000 beds for this winter. We want to be able to do more for next winter. I'll just move on to say a little bit about elective care at the same time. Again, we don't have any end-of-year data available, but I think from the information that has been available to us up until the end of February and the more recent service information, we feel that we have managed to keep the waiting list stable during the winter period, and that our previous predictions about the growth of the waiting list, that we have been able to do better than we had predicted earlier in the year. And again, we'll have that data available next week actually. As far as 52 weeks, i.e. patients who have long waits, we're working very hard to deliver against the mandate, and there was a 52% reduction, and we're seeing good progress. As part of our planning round, we're working across the service, looking at the capacity that we need to deliver and how we can best return to a situation whereby our waiting list is akin to the March 18 number. So there's a determination to do that. And as in emergency care, really focusing on the transformation areas, managing demand, etc. So I think that's a very quick update from me. Happy to take questions.
Before we ask
Matthew's
questions.
doing the rest.
Yes. Shall I pick up on the other areas other than elective and emergency?
Yeah.
Thank you. Very good. So just touching on some highlights from the report, I think it's Firstly, linking to Pauline's access point, it's worth noting that the NHS app is now rolled out across the country for accessing 111 and NHS.uk, and we have about 20% of GP practices now connected to the app. There's going to be a big push in the April to July period to get more GP practices connected, and then an expectation we will run a big publicity campaign in around September next year in order to ensure that it's in place to support running into next winter. And worth noting that of the 1.4 million calls that 111 took in February, about 10% of them were through online contact rather than through direct telephone contact. So we're beginning to make that move, which I think is very good news. In cancer, we have started the rollout of the first long-term plan action in the deployment of pilots for the lung health checks. This is going to be a £70 million programme which we have kicked off the pilots in Manchester and Liverpool, and will roll out to the 10 areas of highest incidence of lung cancer, covering about 600,000 people as time goes forward. We are still struggling to hit the 62-day target, but I think it is worth noting that we have now this year seen whilst we've seen a growth in the number of patients seen, referred and seen by 16%, and a growth of 10.5% in the actual number of cancer treatments coming through the 62-day pathway. So what we're seeing is very large increases in people accessing the service, the NHS gearing up its services very significantly, but not by as large a number as the demand is going up by. So as we're running into the planning round that Simon just referred to, there's a lot of work going on to make sure that we have the capacity in place across the NHS to absorb these double-digit growths in demand, because if we're going to fulfil the long-term plan ambition of improving cancer survival rates, we do need more people to come forward. This is good news that we're seeing this demand, and it's up to the NHS to respond to the challenge. In urology, we've seen an over 25% increase in access of urology cancer services, and we have treated 7,500 more people this year. In primary care, we now have 100% coverage of extended access across evenings and weekends across the country, and we've made really good progress in recruiting additional staff into primary care. We have exceeded the 5,000 target of additional staff. In terms of actual GPs, we are about flat on the whole-time equivalent number of GPs over the last year, which is not taking us to the 5,000 growth in GPs we wanted. Interestingly, we've seen in the past year an increase of about 500 in the head count in GPs, but because there's a change in working practices of GPs, the actual total number of hours in GP land has stayed about constant. Our overseas recruitment programme in Europe has now recruited 110 overseas doctors, of which 50 are now in country and working in practices. And we have a continued pipeline for those, and we've had 780 applications for our improved induction and refresher scheme of doctors trained in England, possibly in the UK or maybe overseas, wanting to come back and practice in the NHS and wanting to go through that programme. So we think that is that's very positive. In mental health, we're on track or are hitting all of the standards laid out in the 5-year forward view. And we are expecting every CCG to meet its obligation under the mental health investment standard this year when this year comes into land. So that's a significant, I think, achievement across the country. On learning disabilities, we will miss the target for the end of March. We set ourselves an ambition in March 2015 to reduce the number of children and adults with learning disabilities who are in inpatient facilities from 2,890 to 1,800. We're going to end the year at around 2,200. So we will have reduced the number of learning disabilities patients in hospital by around 700, but we'll be about 400 short. Now, that's not through a lack of effort across the country, and in London, we are within the target range for the appropriate number of inpatients for the population, and in the South East and South West, we're very close to the target range. But in the in Midlands and the North, both areas are about 200 more patients in beds than we would want to see. So there's a lot of focus now going on, okay, so if working really hard to improve the situation hasn't got us all the way there, what do we have to do differently next year and the year after to achieve this target? And we are looking at the work to make sure that more people get care and treatment, or children care education and treatment reviews before a decision to admit them is put in place, because we know that if you do a proper review of a child or an adult before you admit them to hospital, the chances of you being able to design a community-based service for them is much higher than if you do it after they've been admitted. So there's a lot of work going on around that, and a lot of work going on in partnership with local authorities to say, are we commissioning the right capacity, the right volumes and the right sorts of care to find safe and appropriate and supportive ways of looking after and supporting patients that doesn't mean admitting to patients. So this is still a very high priority for us, and looking specifically at children with learning disabilities in hospital. The count at the moment that when we started this was about 170 children in hospital with learning disabilities. It's now at about 250. Now, there's a couple of things going on simultaneously here. One is we've turned a focus on it, and we are now identifying more children. So the baseline is increasing, and that's a good thing, because we can't help the kids unless we know who they are and where they are. There's also a bit of reclassification, because over the same time period, the number of children in Tier 4 mental health beds fell by about 100. So I think there's children being more appropriately allocated to the right sort of support. But there is also a growing identification of children who need learning disability support or autism support in schools, and we need to make sure that our services are in place, that the default isn't for them to be admitted to hospital, but the default is for them to be cared for in their own homes or in appropriate schools. And I think that's a big challenge for the NHS going forward, is to change our mindset, and as we identify more people with more demand, that we provide the right services, and we don't make the mistake of trying to hit the target and miss the point, because this is actually, in my mind, this is a human rights issue. This is actually about delivering the appropriate care to some of our most vulnerable members of the population, and there's a real opportunity to transform lives here if we get it right. So it's not just about the numbers, it's about what are we doing for this cohort of patients. And then just the last thing I would like to touch on is just around the work that's going on now around the transformation, creating with STPs moving across to integrated care systems. And there's a huge amount of work now going on supporting regions and regions supporting STPs in the development of primary care networks, and creating the work that I think we're beginning to see come through in the planning round for next year, of communities coming together and thinking about population health needs and working much more as a system in order to drive things, drive forward better care. And that work, I think, is making very significant progress now. Thank you, David.
Yeah, Matthew. Any questions for? I've got two questions. One is, I don't know whether Steve may be able to answer this question as much as you, but the 5-year survival rate for breast cancer, there were some figures came out during the month, didn't they, showing that we'd improved very considerably. Do you have? Where do they come from, those figures, and how valid are they? Do you know? I mean,
Can you remember the source? Because I'm just trying.
Yes, so it's a European study that was published last week, and it showed an 18% fall in the deaths from breast cancer over the last 5 years, which means we are now at par with European breast cancer death rates, and it's the fastest rate of improvement in any of 6 major European countries.
Okay, and I had a second question, and I know you, on the people with learning difficulties. What is the irreducible minimum? I mean, what is in terms of how many people we ought to be cared for in a hospital setting. Do we have a view on that?
Yes, we have a view. There is a range of what is felt to be likely to be the appropriate number of inpatients per million population, and so we track each part of the country against that, which is why we know that London, the South East and the South West are at the top end of that range, all of them, but they're broadly speaking at or near to that range, whereas the Midlands and North is much higher. And so this is not an ambition to remove inpatient care altogether. There are some people for whom this is the appropriate care, but at the moment we have more patients in inpatient care than is appropriate. But yes, there are clinical guidelines on where you should expect to be.
If we can sort of make it part of the operations report, maybe on a 6-month, every sort of biannual basis or something, we can track that.
Yes, it's part of the reporting that we do.
Thanks. Paul, yeah, Joanne.
Matthew, I've got a question about the NHS app. So it's
Yes.
great to see that rolled out and available. I've had a bit of a mixed experience, mostly very, very positive. So I was a bit surprised. I've got an NHS log on now. I was a bit surprised at how sort of multi-stage and complex that was, and having to photograph my driving licence and speak a video. But that it worked seamlessly, and I got my log on almost instantly. So that was great. When I got into so my practice is linked up and I can make an appointment. When I got to that stage, trying to make an appointment, I was a bit baffled by the terminology. So the way that they had categorised appointments, maybe, and so on. I guess that's very normal, first iteration of an app.
Yes.
But if I was a bit stumped, then I imagine that's probably going to be quite a common experience. So my question was, what are your plans for gathering user feedback and progressively iterating and improving the user experience?
Yeah,
of the app? It's obviously so powerful.
Both very, very good questions. So on the login, that is a best of breed experience for doing it. As in, previous to that, you had to actually physically go to your GP surgery, and so that we are the first adopters of that as do a video talk into it, login. At the moment, it can take up to half an hour to do, which is less time than it takes to get on a bus and go to your GP surgery, but it's still too long. We are expecting and are piloting internally at the moment mechanisms that will take that down to almost real time.
Which is my experience.
So there's work going on that. We are also introducing at the moment a biometric, so facial recognition and thumbprint, so you don't have to put your password in every time, in response to user feedback, because there is a continuous process of user feedback. What happens when you drop into a GP application is obviously one of the biggest challenges, because they tend to exist in however they've been defined locally, and they haven't been set up for patients to book initially. They've been set up so that receptionists and doctors and nurses know perfectly well what they mean, and moving that into a language which is transparent to an ordinary user is in some ways isn't an app problem. It's how do we get a standardisation of a language that the public can use? But there's a continuous iteration of consumer feedback around that.
And how does a consumer provide that feedback, Matthew?
I think that there's a series of... we have our areas that were in the original pilots where we are continuing to work with. So places like Liverpool and Hastings, there's a number of those around the country. And then there's focus groups. And then I think you can respond through the app to make comments.
Thank you.
So I've got two questions, if I may, David. One for Pauline and one for Matthew. So one for Pauline is, first of all, tribute to the NHS team in all its sense for the sterling work over winter and what's been delivered, and to you and your team for your work with each of the individual trusts and other parts of the system. I'm really intrigued, however, by what happened in February, and maybe it's unfair to ask now, but do we understand why we're seeing a greater admission in February compared to what we were expecting, given that generally flu was less aggressive than we might have expected, and what that tells us for going forward? What's the learning? It's probably very unfair given it's only March.
Yeah, as I mentioned earlier, David, we're doing a piece of work and I should be able to report on it probably about the time of the next meeting. And it's to look at the overall number of attendances and the number of admissions during this whole of the winter period. Because I think what we recognise is that that data is quite contaminated by the transformation that we've put into the system. Okay. So, for example, on admissions, that we are counting, as I mentioned earlier, same-day emergency care as ordinary admissions, and clearly we're trying to drive up the amount of same-day emergency care in the system. And I think I said at a previous meeting, we've had a little explosion of it in the last 12 months. It's gone up by about 12% and increasing as the days go by, but all being coded as admission activity. And we've seen something similar happening on the attendance side, which it becomes more and more interesting the more and more you delve into it and the more data that becomes available, because we can see that some of that attendance increase is because of the new pathways of care that we've introduced around type 3 pathways, urgent treatment centres, co-locating them on the site of a hospital, etc. But I think we do recognise that underpinning all of this for the winter period, we've had some increase in attendances and demand, but we'll be able to unbundle all of that over the course of the next 4 to 6 weeks as we get our sus data, etc. in.
My second question for Matthew is clearly NHS 111 played a material part of coping with demand, which is really great, because that would have gone elsewhere.
Absolutely.
But as you said this morning, NHS 111 started as one thing and has morphed into something else. And it's probably unsustainable to keep that level of growth of that service. It's also, and I'm interested about how we manage the channel and how we think about that relative to digital, for instance, and how we industrialise what we've built so far. If that's a terrible word for a health setting, but you know what I mean.
No, I know what you mean, and there's probably about half a dozen really complicated questions inside that one.
Sorry.
But so in terms of the digital versus telephone handling, my expectation is that we will continue to see double-digit growth in the telephone calls for the next year or two, and then it'll flatten out, and then it should start to drop away as the app and online increasingly replaces it. We've not really done this transformation in the NHS before, so it's hard to know how swift the uptake will be, what the curve will look like as people will get used to a different way of accessing it. But I think the bigger question is, we've moved from 111 basically being a triage service where you ring up and they guide you to who you should go and talk to 111 focusing on trying to solve your problem for you. So sometimes they solve your problem by telling you where else you need to go, but more and more often, more than half of patients who ring up get to speak to a clinician or get a clinical input into it. And we will, increasingly, you'll be able to get your prescription by ringing 111, or you'll be able to get an appointment by ringing 111. So as we move in that direction, we do need to change, and we're going to have to work through the contracts that we let to be clear that growth in demand is a good thing in this part of the health system, and that therefore the contracts need to encourage high quality of service, rapid accessing, answering of the phone, and all of those sorts of things in this area. And that's going to require us to, as we are reletting the contracts, be a bit smart, be smart about what we're asking people for the future.
And do we get access to the data as to what's being presented, what happens, where people go, etc.? Because that's gold dust.
Yeah,
in terms
we
of
have,
then
we
thinking
have
about intervention and prevention.
Data now. About 18 months ago, we commissioned through the North East CSU that David went to visit, a project called Radar, which takes all of the data out of the other 111s, tracks what the advice was that was given to the patient, and then tracks where they actually went. So we can see if someone's told to go, how many people were told to go to a pharmacy, and how many of those people actually pitched up in the A&E anyway. Yeah. So that increasingly that's part of us modelling whether the digital algorithms that we're using are picking up the right patients and giving the right advice to the right people.
Great.
Thank you. Matt, on finance.
Yes, so I'm presenting a month 10 finance update. Probably the last time we'll cover just the commissioning sector in one of our board meetings. At month 10, the forecast outturn for the commissioning sector for the year as a whole was a surplus of 706 million against a planned surplus of 265 million. Within that, we anticipate that by the end of the year, we'll have an overspend in the CCGs of around 250 million spread across about 35 CCGs, driven largely by overperformance on acute contracts and by under-delivery on QIP. As has been the pattern in previous years, we will see that offset by underspends in some of our direct commissioning budgets and in some of our central nationally held budgets too. I think the key thing for the boards to be aware of is that on a risk-adjusted basis, we are confident that the overall surplus on the Commissioner side will be sufficient to balance the NHS group as a whole for the year 2018-19. And we're clearly, I'm working very closely with Elizabeth on the NHSI side to ensure that we land the year in that fashion. We're also focusing on understanding the underlying causes of those CCG deteriorations in financial performance to ensure that we can set sustainable plans in those CCGs and in indeed all commissioners and providers for the year ahead. That's the first year of the sort of long-term plan period, and given the decisions that we've taken to rebase control totals onto a stretching but achievable basis and not to hold very material reserves for 1920, that work to understand those underlying causes and ensure that they're addressed in 1920 plans is absolutely crucial in the coming weeks.
Julian, any observations you'd like to make having been here for just over a week?
No, probably on this, not really. I mean, as Matt said, and there's quite a lot of work to do just to coordinate closely between E&I over the next kind of month as we close the accounts.
Any questions for Matt? No? Excellent. So item 5, Emily. Where is Emily? There's Emily. There
Not
you
quite
are.
as far away as Pauline was. So the paper in item 5 presents the NHS England and NHS Improvement Funding and Resource 1920 plan, supporting the NHS long-term plan. And the document is provided in an annex, and then there's a covering paper. Really, we're just asking the board to do 3 things. One is to recommend the publication of this document on the 1st of April on the NHS England website. Secondly, to note the 1920 allocations and to ratify the 305 million allocation of our capital mandate. And third, to delegate any in-year adjustments required to the CEO and CFO, recognising that in bringing the 2 organisations together, we've had to make some judgments about how to create combined directorate budgets, and we expect that as the operating model, the detailed design is done during the year, we may actually need to make some adjustments and move funding between directorates in order to make sure we can meet our goals.
Maybe this is a question for Simon rather than you, Emily, but I think it's now for the 2nd year running, life expectancy has stalled, and the figures were out yesterday, and health inequality is such an important part of our plan going forward. Is this a trend, or is this, it's 2 years now?
I think we can now conclude it is a trend. The ONS data that you're talking about, David, particularly found a statistically significant reduction in life expectancy for women in poorer areas of England, by contrast with women in better off areas in England. The numbers in some other parts of the UK were not sizable enough to be able to draw statistical significance from. But yes, I think that clearly is the case, and we've had the discussion previously with the evidence review from PHE, and as part of our LTP implementation, we are requiring each part of the country to show how they are using the extra inequalities related funding they're getting to deliver some of the best by inequalities reductions that were in the long-term plan itself. But with each sort of successive publication, there were some material that the actuaries put out a few weeks ago, looking at life expectancy at 65 rather than life expectancy at birth, which is what the ONS data are. It's all kind of confirmatory that is what's happening. I think, from memory, I think the ONS data are for the period 2012 to 2015, 15 to 17, so there's a lag on these things, obviously, but that does definitely appear to be the case.
I've been struck, I mean, Matthew may want to comment, I mean, talking to integrated care systems, there is a growing focus on the social determinants of care and on inequalities, which I don't think was there to such a great extent even 2 or 3 years ago. Is that right, or?
No, I think that's very, very fair. All of the STPs have had at their core, and I think it's partly the upside of having local authorities involved in these discussions as well, the sense of what is the population that you're serving and what are the health needs, and inequalities is playing out in that. We've also, since we started doing a lot more work on looking at the inequalities impact of things that we're doing and developing ways of measuring whether what we're doing is widening or closing the impact. So I think just generally the NHS is much more focused on this, although I think there's still a lot to learn about what is the right things to do in order to deliver the output you want.
Good. Any questions for Emily? Can we approve the paper then, please?
Oh, sorry. I know everybody gets. As Emily said, this is our sort of going in position for the 1st of April. Yeah. We will obviously be doing significant further work over the next 4 to 8 weeks as part of the bringing together of ENI, the leadership transitions that are in train in various parts of the organisation. So we'll be coming back to you, as we discussed this morning, during May with a refresh on what this looks like. But we have a legal obligation to publish this material before the end of the financial year, and this is what we're doing this afternoon.
Yeah. So we'll have a detailed discussion at the next Delivery, Quality and Performance Committee, and then at the next joint board we'll bring it back. Okay.
Good, thank you. Well, next item, over to you, Dido.
Well, I suspect I just pass straight over to Julian. Julian's been working with me on the workforce implementation plan, which we both prefer to call the NHS People Plan. And I think, Julian, you're going to give us a verbal update of progress. We are due to publish an interim plan during April. So over to you, Julian.
Thank you very much. Thank you. I'll start with a reminder that on the publication of the long-term plan, it was announced we would have a workforce implementation plan that would support the delivery of the long-term plan, with interim recommendations in April and then the full report to follow in the autumn. And as Dido said, I've been working alongside Dido with a number of colleagues over the last 9 weeks to pull together the interim report. I think it's important to say, first of all, about the approach we've taken with this. We've established, rightly, I think, a very inclusive, wide-ranging group of colleagues that have come together in service of ensuring we do justice to the range of activities going on in relation to workforce and staffing across the NHS. And that starts with the steering group, which is a collection of around 50 colleagues from across the arm's length bodies, Royal Colleges, staff side organisations, NHS colleagues, special interest groups. Everyone who has an interest in workforce across the pantheon of health and care is involved in this work. That in turn is supported by a working group, a smaller group of around 20 colleagues that's met weekly since we started in mid to late January. And then we have the engine room, if you like, of the 5 key groups. First one being the future medical workforce, chaired by Steve Powis, and also supported by Sarah Hurley on dental. The future clinical workforce, chaired by Ruth May. Also including Suzanne Rastrick on AHPs, Keith Ridge on pharmacy, Sue Hill on healthcare scientists, making the NHS the best place to work, which Dido referenced in her introduction, given feedback from colleagues as you've been out and about, key part of the work. That's chaired by Navina Evans, Chief Executive of East London Foundation Trust. Leadership Talent Development, chaired by Peter Homer, and Technical Skills Digital Enablement, chaired by Sir David Behan, Chair of Health Education England. Those 5 groups supported by cross-cutting and enabling work streams on workforce analysis, workforce architecture, what part of the system does what in relation to workforce planning and strategy, transformation and new roles, and international recruitment. Now, that's the architecture of the, if you like, the framework and the project plan, but it doesn't quite do justice to the sense of how we've gone about this work. And I was struck by your opening remarks, Chairman, about your visits and about how it's very much about relationships where things work well in terms of integrated care systems, and also Pauline and Simon have paid tribute to NHS staff in pressing times, delivering extraordinary results. And if ever there was a reminder, it is all about the people. And that's the spirit in which we've pursued the People Plan. And at the heart of the People Plan is the hypothesis, which is based on significant research and evidence. And almost exactly a year ago, the report that was commissioned by NHS England into the relationship between staff engagement and productivity, led by Michael West and the King's Fund, which concluded that high levels of staff engagement are associated with low rates of staff sickness and absence, and therefore lower rates of bank and agency staff. The size of that effect is significant. An average upward shift of only 0.1% on scores on a 5-point scale of staff engagement is associated with a saving, an average saving on agency bank spend of 1.7 million. Now, I think that's just the start, really, of the opportunity and the scale of what we can achieve if we pay real attention to our people and the engagement of our staff. And just to reinforce that point, if we draw the lessons from the CQC NHSR use of resources assessments, it's clear that those trusts that are rated outstanding, all of them reside in the top quartile for staff engagement. All of them top quartile performance on pay costs per weighted activity unit, top quartile on reduction in agency spend, retention rates, lowest sickness absence, significant advances and leading the charge on use of technology and digital innovation, all have in common a clear and systematic improvement method, positive culture and leadership, and delivering financial sustainability. And given the challenges that many of our organisations are facing at present, these are the ingredients really that we need if we're to move the dial on a range of performance issues. But the starting point for our plan is about the importance of the engagement of our people, because the importance of that cannot be overstated in relation to the delivery of high quality and sustainable care. So we've taken an approach where we've attempted to engage far and wide across both, obviously, arm's length bodies and nationally, but also across the service. We've used a range of channels, including weekly e-bulletins that all the chairs have contributed to and been part of. We've had an interactive space on the Department of Health and Social Care's site, Talk Health and Care, where we've had significant ideas and discussions and comments and feedback. We've used the steering groups, stakeholder events. We've had several roundtables with colleagues across the whole NHS in different sectors and different roles, nursing directors, acute and specialist CEOs, acute CEOs, community, HRDs, and so on. And I think most encouragingly, we've had a very strong response to the letter that Dido and I sent out on the 6th of March, which listed out some of the key themes that were emerging. We've had 105 responses representing over 250 organisations, all of whom have shared both their views and examples of good practice, and also their reinforcing of the point about the importance of engagement of our people. And in terms of the themes that have come back to us based on an analysis of those responses, making the NHS a better place to work comes out as a clear theme and will be a big part of the work that we do and see in the report. The emphasis on flexible working, more support on health and well-being. Only a few weeks ago, we saw the publication of the Pearson report into the mental well-being of learners and staff within the NHS, which had some important things to say about what we can do more work on. The need to look at different generational needs, particularly in relation to the development of flexibility and technology, the importance of portfolio careers, and the crucial underpinning importance of engaging our people. Secondly, the importance of the right leadership culture at all levels of the service, particularly line managers, who significantly influence the experience of our staff across the service. The importance of central bodies exhibiting the leadership they want to see. That was stressed very much as part of the response we saw. And out of the process of engagement, one theme came out as urgent that we require significant action on over the next few months, and that is the challenges in nursing. And that's something where we've spent a lot of time with Ruth and her team and colleagues in HEE and DHSC and NHSE and NHSI, really looking hard at what can we do to move the dial on this over the next few months, as well as thinking about the sustainable solutions moving forward. And that's something which we are working through, the specific interventions that are going to help us make progress in that area.
Yeah. And just from the nursing perspective, Ruth.
Yeah, absolutely. So I had the privilege to hold my very first CNO summit middle of March, and I'm thankful for members of around this table that were there, particularly Julian and Dido. And the discussion, the second day was about workforce, because it is the single biggest challenge that a director of nursing, and whether it's a ward sister, a community team leader, is facing any day, 24 hours a day, is how many nurses have I got? What is the nurse makeup, their skill, their experience, their expertise, their background. So it is by far the biggest challenge that nurses are facing, nurse leaders are facing, and indeed me now as a new Chief Nursing Officer. So we welcome the discussion. We welcome the honesty and the frankness by which we were able to have that discussion about some of those challenges. And what we were working with directors of nursing around was the details of what potentially some of those solutions could be as part of Dido's and Julian's report. Really resonated with the nurse leaders when we were in Birmingham a couple of weeks ago. So lots of work being done. Lots of this work has been done previously. Now is an opportunity to really, for me, to land some of this so that we can make a real difference. And not just in the long term, but what we can do now, this month, next month, right up to the September, about how we get more potential nurses coming through on the graduate scheme starting in this September. So we want to do things that actually land right now as well as into the future.
Ian, did you want to give any reflections?
Generally on the work
yeah.
that has gone on. No, I think the points that have been made about a participative, engaging approach, I think I'd want to echo. I think Julian's led it with distinction, if I may say, and pay tribute to him during this period of time. I think there's two issues. I think there's the one that Ruth has just made about what is it that we need to do now. I think the covering report flags up some important issues on nursing around shortages in learning disabilities, just to connect back to the report that Matthew took us through, mental health. I think there's geographical variation in this, so how we begin to connect with the universities, the further education institutions to actually begin to do something about this, I think is critical. I personally think we need to sort out CPD. 50% of our current staff will be working for the NHS in 20 years' time. But I think we use CPD sloppily and interchangeably. We confuse upskilling, which HE is funded, with what the employer's responsibilities are, what people need to do to continue to revalidate and use their licence. So I hope as we can go through this next period that we can make progress on this. I think from my point of view, I've been around for a while, and I think there's conversations taking place on workforce that I've not seen take place before. I think people are working together, and I think it's provided a platform of that we're able to build consensus and some agreement about what the next steps are, whether that's the work that Steve's been doing on medical education and Ruth on nursing, some of the challenges around technology and what that means, not just for clinical staff, but for how many analysts we'll need in the next 15 to 20 years as well. So I think Julian's done a fantastic job, and the interim report will provide a platform on which we can build beyond 1920. So
maybe it's just worth sort of just to be clear, the interim report will aim to set out a more detailed vision, building on what was in the long-term plan, so a more detailed vision for our people for the next 10 years. It will also aim to set out some practical actions that we intend to take now. In fact, some of the teams are just getting on with doing it now, but be really clear about what we're going to do in the next calendar year. And then thirdly, it will set out what additional collaborative work we need to do to build the full people plan. And I keep saying to the teams, this is not a crash diet, this is a new way of life. We will need to keep working together on this across the different arm's length bodies, with all the Royal Colleges, the unions, all of our people, because actually thinking about how we evolve our workforce is probably the most important job of leading the NHS. So it's so exciting to see everyone actually working together on it. But we will only have the beginnings of that when we publish the interim report. There's an awful lot more work to keep doing.
I think the work that Julian has been fantastic, and we're doing a lot of work at a really high level in the NHS. For me, the real acid test is going to be, does a typical NHS board regard workforce in the same status as finance? So we'd expect to see an audit committee as part of a board structure, but I bet you very few have got a workforce committee that's looking at the workforce needs of their particular organisation going forward. So anything we can do to promote that, I think is really important, because this has got to be bottom up. And if we can't get the trusts engaged in this, we'll lose it. We'll create this great, fantastic architecture up here, but it won't connect to what people perceive on the ground as being the real need.
Well said.
No.
I thought your theme for Julian in your deck had a number of really important ideas in it. One of them is around how we equip clinical staff to take on managerial roles, and in particular leadership roles. And if you look back, we've relied hugely on the NHS Leadership Academy to help prepare clinicians for the huge amount of change, ICSs, digital, the whole lot.
Yeah.
How much emphasis do you think that will get in your final recommendations?
I think it's central, Noel. I think that the way in which I think we've seen positive shifts across the NHS over the last 10 years or so in clinicians taking on leadership roles. I think we're seeing more, certainly in my own organisation, the new generation of clinical directors gives me a lot of optimism about the way that younger clinicians are really motivated by getting involved in improvement science. Exactly. And many of our junior doctors get involved in the work we do on the Leeds Improvement Method, and I see this in other trusts as well. And Kathy, the work that we're doing as part of the VM cohort, but indeed the other trusts that are involved in the vital signs work, we're seeing the engagement and involvement of many clinicians in that work, because the systematic, evidence-based approach to this resonates, I think, with many of our clinicians across many professions. And I think we need to encourage that. I'm sure we'll be saying that. Leadership in the round, though, is important across all backgrounds, and I think the way in which we're able to put a premium on values and behaviours as part of this is important, particularly the exhortation that we have from colleagues in Virginia Mason, which is about is all about how we add value to our patients' experience and how we respect one another, and how leaders and I can picture the Tai Chi Ono sketch, big eyes, big ears, small mouth, and I think these are the things that kind of resonate in terms of learning some of these methods that do actually genuinely make a big difference to the way that frontline teams are able to feel empowered, get involved in changing patient pathways, removing waste, and adding value to the experience of our patients. And clinical leadership is fundamental to that.
Very good, thank you.
Kathy.
Just one thing, just sort of building on that and what Andrew said about making sure it's at the front line. I would just add to that sometimes those things are actually done most by those who are most able, bigger, and probably have the least issues. And I just wonder, as you go forward, being proactive at the front line is supporting the most challenged in terms of geography, in terms of ability to get workforce, to actually embrace this with a bit of help earlier than the others. So you actually change that dynamic, which otherwise there's always a lag.
Yeah.
And there's a lag in the place that needs it most very often.
Good. Well, Julian, thank you very much for coming today, and you've always done a great job.
Thank you.
All the feedback has been incredibly positive.
Thank you.
Thank you very much.
Thank you.
Thank you. Establishing integrated care systems, Matthew.
Thank you. Yes, so let me give you an update on where we've got to on integrated care systems. You see, in the long-term plan, we committed that by April 2021, integrated care systems would cover the whole of the country. It's probably just worth asking why. Kind of why have we put this at the core of the long-term plan, and think about what we consider to be the big challenges facing the NHS going forward, particularly around prevention, around an ageing population, around the need to support people with long-term conditions and frequently multiple long-term conditions, and increasing the ability of people to self-care. And that requires us to take a systemic view and a system-wide view in partnership with other organisations, in partnership with local government when we're thinking about the things that drive ill health, when we think about housing or we think about education, and in partnership with the voluntary sector, which is delivering support to many of these people at large scale across the country. So we've created the integrated care systems to be integrated and to integrate the care around individuals, and we want them to be able to look across their populations and take responsibility for managing the resources, improving quality and access and outcome, and focusing on the reduction in inequality by building partnerships with other organisations, and by driving the complex system changes that we're going to need that will change us from the acute hospital being the centre of a web by which things get sucked into, to saying no, acute hospitals are there for a specific thing, for a specific group of patients at a specific moment in their lives, and the ambition of the NHS should be to keep people out of hospital and keep them healthy or keep them managing their own condition and maintain their liberty. And in order to do that, we need to have a structure which starts not at the million people in a system, but starts at the 30 to 50,000 people on a housing estate who are supported by a community mental health team, a community social care team, and a primary care network. And how do we engage in the particular needs of a community? And when that works well, we'll find that there are networks of networks that build up, probably at the level of town, what local authorities call place, but at the level of what do the people of Bradford or Barnsley or Brighton or Bournemouth need in order to maintain their health, and what decisions can you not take at the size of 500,000 people, but you actually need to think at the size of 1 million people, because you need to decide how many tertiary trauma centres you need, or you need to decide what your stroke unit's going to be, or you need to decide a workforce plan at a population that's large enough to make a difference. So we are working to put in place across the country that architecture that starts not at the top but starts at the bottom. It starts at the neighbourhood, builds into a place and engages with partners, and then thinks at a system level when it needs to. And our best integrated care systems say that 80% of the decisions are taken locally and that 20% makes its way up to the top, not the other way around. And I think that is a philosophical approach. We are challenging them as part of the long-term plan design to rethink out-of-hospital care to bring together the pieces so that an individual is treated around their needs rather than multiple different services arriving, sometimes one in the morning, one at lunchtime, one in the evening, doing bits of services, and then you don't see anybody for 3 days and then someone else turns up. But how do we integrate care around people's homes and people's lives? How do we reduce the pressure on acute services? How do we move away from having to open more beds every year because we can manage people closer to their homes? How do we give people control over the decisions about their own health and give them their liberty back? The conversation that we had about people with learning disabilities could just as easily be about the 30% of our hospital beds who've got people in them who are frail and elderly and are in the hospital largely as a place of safety rather than because we're doing anything to make them better. And a better place of safety would be their own home with the NHS wrapped around them there. And we're challenging ICSs to say, so what does that mean for population health? And what are the big transformations we need, both in the way we work and the way we use technology in order to do that? We've now got 14 integrated care systems up and running, of which 8 of them are operating effectively in a devolved manner, and another 6 are in shadow format. And we use those 14 to work with them to develop what they can do, because this is a new model that we're bringing in, but also to develop the learning that we can spread to the 28 that are still to follow. So none of them are the complete entity that can deliver the vision that I've just given you. Many of them are on that journey, but they also need to be able to work out how do we do it more simply behind us, how do we create the right governance, the right attitudes, the right behaviours, the right financial flows, and in order to be able to achieve those.
A good view of that. Can I just ask, Tim, you've seen this in another part of the world. I mean, what's your observations on how it's developing over here?
It's great. Thank you for asking. Well, first of all, I'm a bit jealous because what you're planning is at a national scale is tremendous, and I see the ingredients. I see the work you've done in creating population-based metrics, which is a critical component of this. And one could imagine in a future way population-based metrics being the for lack of a better term, the methodology for accountability for integrated clinical system or integrated care systems. It's tough work. I'll just underline one thing that Matthew said, which is really easy to say and really difficult to do, which is that you talked about the different services coming into the individual's house. Each one of those delivers a service which in and of itself is highly specialized and therefore needs to be a distinct service because it is highly specialized. Coordinating across those is really, really challenging. And it has to occur at every level of the system, that the mindset that you are not just about delivering your narrow service, which is maybe meals to an elderly person that can't get a meal by themselves otherwise, and coordinating that with physical therapy, which is really, an entirely different service and needs to be distinct, and yet in the care of an individual it needs to be coordinated. So I see both. I'm jealous of the vision and the plan. I see a lot of challenges in the implementation. Knowing, of course, that you've got the data, or you're beginning to put together the data that will be necessary to judge whether or not you're actually achieving those milestones. So, thank you.
Thanks. Anyone else? Any other questions for? Oh, Laura, sorry.
I just wanted to ask Matthew whether the work that's trying to produce the LICRAs, so the shared data, are we beginning to see that making a difference to those ICSs, or are they at the moment using things that aren't quite what we envisage LICRAs becoming? So I suppose it's sort of what's the meshing of the two, and are we seeing it actually make a practical difference to the ability to run integrated care?
So the latter, at the moment, they're sharing data in all sorts of ways in the local health and care records. The first contract to deploy a local health and care record was let by the Thames Valley area last week or the week before. So we're at the early stages there. But what we are seeing across integrated care systems and across STPs is a more openness about sharing the data that they've got in order to try and make population health planning possible.
Okay. Thanks.
Thank you, Matthew. Thanks very much. I think you're doing some great work in this area, and the data that we saw a glimpse of this morning is just fantastic, I think. So the NHS Assembly, Neil, where's Neil? Oh, Neil, you've moved up there. Good.
Usual.
Neil, over to you.
Okay, so thank you. So when we talked to stakeholders about the NHS Assembly, there was strong consensus that it should be round about 50 people. But no one envied us the task of trying to work out which 50 people. And so it's been quite an incredible process. And we've had some fantastic applications. So over 500 people from different walks of life involved in the NHS. And if you remember that the board had a vision of making this a really diverse and inclusive group of people, so drawing from some of the faces you'd expect to see, who are leaders of organisations, leaders of systems, but also having some new faces, people representing the voluntary sector, patients and carer voices themselves, and frontline clinicians. And so what we try to do is to try and build an assembly that's drawn from all of those constituencies. And you've seen the results that have been circulated to you, but it comes with 8 clinical leaders, 11 frontline staff, 10 health and care system leaders, 9 from the voluntary sector, 10 from a patient carer and public voice background, and 8 others, and recognising that obviously people wear a number of different hats, but it is diverse in the way that the board wanted. It does have a number of prominent names, so there'll be chief executives and professors that you'll recognise, but it also has lots of new faces. I'm particularly pleased that there's a member of or an ex-member of the NHS Youth Forum, who's now a third-year medical student, who would be a member of the Assembly. She's fantastic, an active participant at the Nuffield Health Summit last month. There's a neonatal intensive care nurse, a paramedic, a midwife, a radiographer, occupational therapist, NHS chaplain, as well as GPs and doctors. There are at least 2 people with their own individual health budget, as well as parent carers for young people who also have health budgets, disability advocates and carers, as well as prominent commentators. So I think it's a really diverse group of people, and I think it will be really stimulating conversation. In terms of the diversity, it's 53% female. We have people from their 20s to their 70s. We have a pretty good geographical coverage, and we have a quarter of the membership which will be BME. So I think it's been a really good process. It's still been very hard to say no to lots of fantastic people, but bearing in mind that people will serve a variety of different terms, there will be opportunities in future to join the group. So I think it does build on the lessons of Victor Redabouali's task force. It has a group of new faces, and I think we need to think about how we're going to make it work and how we're going to make it do the job that it needs to do.
I mean, really fantastic. Ruth, did you want to add anything?
No, we've just been working over the last couple of weeks to making sure that we have a really diverse and a fresh faces and names to it. So well done to Neil and the team for getting that.
Any No, I just think it's just a really diverse, interesting, feisty group. So we look forward to working with them.
Indeed.
So well done, Neil. That's a really great effort.
Thank
great
you.
result.
I think if it's as feisty as a youth forum, I think it will be special.
And your next item as well for you, number 9, the Empowering People and Communities Task Force.
Yes.
Yeah, no, I'm very happy to co-chaired with Victor. of whom we would like to thank for his outstanding contribution, the task force members. Nice to see two, I think, isn't it, Neil, who are on the Assembly. Very good job they did too. And also many of the citizens and carers who participated in the programme, which was a task force over 12 months with quite a specific and focused remit. A couple of insights we would want to share. Firstly, I think we felt and do feel very supportive that the Assembly is designed. We have a number of fantastic names who are going onto it, and the task force was very, very supportive and thoughtful in making recommendations about the design and the delivery of the Assembly. I think we also felt that the way in which we work was quite important, reaching out to a broad range of stakeholders, citizens, carers, as well as the voluntary sector, and felt that it gave a good conduit for those people to feed in their thoughts and ideas about what needed to change in the long-term plan. So one of the strongest themes that came out of the 12 months of work was a desire to see a better focus on health inequalities, and that was great to see in the long-term plan with that being picked up. I think the second thing was really making sure that in the implementation of the long-term plan that we continue to engage a breadth and depth of communities, individuals and organisations, and continue the spirit of co-production. So good to see that that's continuing to be a part of not only the Assembly but the development of the implementation plan and framework over the forthcoming months. I think we also felt that it was important to engage people in different methods, and social media was an important part of that task force, and it enabled us to reach out relatively cheaply to large numbers of people who I think felt they had their voice heard. So in terms of next steps and perhaps legacy of the task force, much of the work is passed over to the Assembly. I think absolutely welcome the voluntary sector and patient partners on the Assembly. I think as we talked about, really looking at 2 or 3 areas in terms of our achievements, one of which is particularly continuing to ensure co-production is a big part of what we do. Continuing to make sure that the national programmes build on their commitment to have specific objectives around inequality and targets, and looking to see them being developed over the forthcoming period, and just welcome the ongoing focus which runs right through the plan on the commitment to health inequalities and continuing to engage citizens and the voluntary sector.
Thanks very much, Michelle. Ruth, did you want to add to that?
Nothing else to add. Thank you.
Anyone got any questions for Michelle? Or could you thank Sarah Geeta very much, Neil, on behalf of all of us for organising the NHS Assembly so well? I know she worked very closely with you on this. Could you just say, just say she's done a great job? Michelle, thank you very much for that. Is that finished now, that task force? Yep, great. Yes. Good. Well, it's borne fruit.
Yeah.
Excellent. Thank you very much. So, Emily, the joint standards of business conduct.
We're asking the board to ratify the policy which is attached to the paper, which will now cover colleagues in both NHS England and NHS Improvement. There was a difference in the two policies before we started, which largely stems from a different definition of what a responsible person is in the two organisations. We discussed this at the executive at the beginning of the month, and agreed that we should adopt broadly the policy that already existed in NHS England, which had quite a broad definition of who a responsible person was. And what that means is that any any of our staff who are band 8D and above will now need to make declarations of any potential conflicts of interest. Will obviously, the platform that's already available for NHS England colleagues to do this will be made available obviously to NHS Improvement colleagues as well, to make that easy to do. And it's in the interest of transparency and making sure every decision that's made, we're completely transparent on both who's been involved and what any potential issues might have been.
Can we approve that, please? Oh, sorry. Yeah. Yeah, do, yeah.
So sort of maybe wearing an audit and risk committee
Yes.
hat, Emily, I kind of looked at that quite carefully and I thought it looked great. Two just sort of small comments reflecting on a couple of the practical challenges that we in NHS England have come across in the last sort of number of months, and thinking about how this could have helped with that. So it references the social media policies of both organisations.
Yeah.
I couldn't find the NHS Improvement one, but I reminded myself, looked at the NHS England one, which I think is very good, actually. I think it might be helpful to add that in the list of related resources at the back of the document.
Yeah.
That was one thought. And the second thing I was thinking about was the issue about, particularly at a time when, as a result of transformation, there's quite a lot of fluidity and people are moving in and out of the organisation a bit more than normally. The issues about new jobs and waiting periods and so on, which I think is not particularly covered in this. And I just wanted to ask you, how do we make sure that our staff understand what the rules are applying to any other employment they might take on subsequent to being in one of our organisations?
You mean how any obligations in this policy would continue if they changed roles? Or?
No, I'm more thinking about what it's whether there's any gap required between this job and one that relates on similar subjects, or in anticipation of a move, how that might affect what they're doing here.
Yeah, it's a good point. We do have restrictions, obviously, with what employment people can take on and what the gaps are, and those are available in our policies, which are on our website. But we can again make a link, perhaps, and make that more obvious.
It's important that people are, well briefed on that now.
Absolutely.
Okay, thanks very much. Ruth, the slavery and human trafficking statement.
Of NHS England in line with the Modern Slavery Act, and it's a paper for us to, I hope, approve. The statement that Simon will sign, it sets out what we've done and what we're going to do, and Hilary Garrett, my deputy, has been leading this and is a real expert nationally in this area. So I have nothing else further to add, and of course I'll try and answer any questions if there are any.
Okay, thank you very much. No? Yes. Right, thank you. Is Stephen Groves joining us, or yeah? So the EPRR, Matthew or Stephen?
Yeah, well let me just give a 30-second introduction while Stephen makes himself comfortable and welcome. NHS England is statutorily a Category 1 responder under EPRR, so it's one of our statutory obligations, which I hold as the board member, and Stephen does all the work on, which is the way these things are supposed to work. So I think from this board's point of view, people will now understand that this is no longer a theoretical risk. Just in the past year, the Salisbury Novichok, the clinical waste issue, MERS and monkeypox, EpiPens, the collapse of a major domiciliary provider, have all happened. And within the time I've been here, we've had two major terrorist attacks in London. We've had the Manchester attack, and we've had WannaCry. So we depend very heavily on the deep expertise of the EPRR team, and part of what we've done quite recently is conduct an audit, which has come back and said, look, stuff is changing now. There are more incidents than they've ever been before. They now overlap, and quite importantly, the nature of them changes. The NHS is very good when a crisis happens and 48 hours it's all over, but we now have incidents that run on for weeks and weeks and weeks, and other ones layer on top of them, and the team that Stephen leads never leaves their post. And it's so they're not personally responsible for the EU exit programme, but the expertise they have is the basis on which we've built the whole of the EU exit preparation programme through the NHS, because the NHS knows that this is best practice. So, Stephen, thank you for coming and walk us through the paper, and I'm sure people will have interesting questions.
Thank you, Matthew. As Matthew says, we have a number of duties under the Civil Contingencies Act as a Category 1 responder, but also under the NHS Act. And one of those requirements is that we bring a paper to the board each and every year to talk about our responsibilities and what we're doing to meet those responsibilities. NHS England has an additional responsibility that we are required to make sure that we, NHS England, but also the NHS in England, is properly prepared to deal with the range of threats. And I think Matthew's covered a number of the threats and hazards that we deal with. So since Matthew brought a paper at this time last year, my team and I have been involved in managing 65 incidents, 10 of them which required some significant national coordination, and 5 of them occurring consecutively. As Matthew alluded to, we were involved in the coordination of the Novichok and the other incident in Salisbury and Amesbury, and that was quite a protracted incident and dealing very sensitively with counter-terrorism policing and other partners, and managing the consequence of that very closely with Public Health England and the Department of Health, along to things like the disruption of a clinical waste provider. And clearly it's extremely important that our NHS organisations can dispose of clinical waste and get them off-site as quickly as possible. So quite significant disruption to hospitals was a potential if this had been allowed to continue. In September last year, we saw a case of MERS, Middle Eastern Respiratory Syndrome, in the country, which was very quickly followed by 2 unrelated cases of monkeypox, the first time in UK that we've ever seen cases of monkeypox. And this allowed us to test our high consequence infectious disease arrangements, and I'm pleased to say they worked very well. Again, dealing with a shortage of EpiPen, there were incidents where we had a number of malicious parcels sent to NHS organisations and academic institutions, and again working very closely with Public Health England and counter-terrorism policing to make sure that the product that was being sent around wasn't harmful, but also making sure that we were communicating with organisations around what they should do if they were to receive such a parcel, and dealing with those. We've been dealing with things like the collapse of a domiciliary care provider and clearly significant facilities management providers either going into administration or pre-pack administration. So making sure that we have oversight of arrangements such as that, but also that the NHS organisations have plans in place to deal with that and to mitigate against the impact of those, and clearly continue to provide safe and effective patient care, and that's most important. So part of our oversight is to make sure the organisations are doing that, and we do that by undertaking an annual assurance exercise. So each and every NHS provider organisation takes a statement to a public board meeting such as this to look and say how they're meeting the requirements of the core standards, and they detail exactly what's required of those organisations. We review that at a local, regional and national level, and we indeed do the same exercise, and we're peer reviewed by an organisation, and this year we were peer reviewed by NHS Improvement as part of that exercise. I'm pleased to say that the results of the assurance give substantial compliance against the EPRR core standards, but also allow us to build on that to develop a work programme for next year. The other part is around the development of guidance for the NHS, and I'm really pleased this year, in consultation with Surgeon General, Ministry of Defence and clinical colleagues, that we were able to produce and publish some clinical guidelines for dealing with mass casualties. A lot of the expertise came from the Ministry of Defence and their dealing with events overseas and during battle, and therefore we've drawn on that, and this is now available to all NHS organisations and indeed on the NHS England website for use should we come across catastrophic injuries, the type of which MOD have the experience in dealing with. So I'm delighted that we were able to produce that this year. And the other parts are around other guidelines for dealing with the arrangements for reception of mass casualties and how we work with our trauma centres. So I'm really pleased that the work that we've continued, the excellent team that I'm working with have been able to deal with these incidents, to provide oversight and to provide assurance to Matthew and to you, the board, in relation to our arrangements that are in place.
Thank you. Thank you very much, Stephen. Any questions for Stephen? Tim?
I'm interested in and you know that the board and the NHS more broadly is interested in the interconnectedness of the health information systems in order to deliver more coordinated care, and with that greater interconnectedness comes increased cybersecurity risk. So I'm just interested about your sort of, as that ramps up over the coming years, as I expect everyone wants it to, is the attendant oversight and contingency planning also keeping pace with that?
Indeed. So we responded to the WannaCry incident last year, and I think we learned an awful lot from that. We've put in place arrangements for how we respond to cybersecurity. We clearly work very closely with NHS Digital, who provide oversight. And I think one of the major things that we learnt were around monitoring where organisations are applying patches when they're available for issues which work for them. So most definitely, I think it's extremely important. We've done a number of exercises in relation to how we might respond to a cyber incident because of its potential impact on patients and patient care. So it's extremely important to us, and I think something we'll continue to build on.
I think we did learn a lot from the WannaCry incident, not least how do you communicate with your people when the communication systems go down. And so we've developed new ways of ensuring that we're not thrown if email gets turned off, simple stuff like that. But the huge advantage of the EPRR approach that we have is that when that incident happened, I called the incident within probably an hour of it starting to run, and at that moment there was no question what the command and control was. There was no debating about who's in charge and who carries it. There was clarity instantly in place about where decisions would be made and who could call on resources and so on. And that was the first time I'd been right at the centre of one of these, and it is extraordinary when you watch it work how well it works.
Unaware of what you do most of the time, which is fortunate, really. But, thank you very much for the report. Thank you.
Thank you.
Matt, anything useful to seal?
Nothing in particular to draw your attention to. I've got Leslie Tillotson, who's worked very closely with me as custodian of the teal and custodian of the seal, and done that with great care and diligence.
Thank you. Leslie's sitting over there. This is your last board meeting, I think, Leslie, and can I just thank you very much for all that you've done. You've been brilliant, actually. You've helped. Your notes really helped me a lot. Just before we finish off, I mean, Stephen and Kathy have been, I don't know how long you've both worked for the NHS, but you've worked for NHS Improvement and before that with Monitor for a long time. I mean, and the TDA in your case, Kathy. If you'd like, any reflections you'd like to sort of leave us with for a couple of minutes at the end of the meeting?
I've worked in the NHS since December 2003, through the whole Foundation Trust regime, Monitor into NHS Improvement, and I've thoroughly enjoyed it. The thing that has always struck me is the dedication of the staff in the NHS to care for the patients, and all I'd like to do is to wish you and NHSI and NHSE all the best for the future and delivering the 10-year plan.
Thank you. Kathy?
Yes, thank you. I've been in the NHS for almost 36 years, so it's a long time. And I've obviously seen it from absolutely the front line all the way through, been very, very privileged to work at every level in the NHS. And like Stephen, I think that my sense is that, you know, the 4 million people or whatever are incredibly dedicated, and I think we are remarkably lucky to have such dedicated staff. And I think as I reflect, I look back and I think if only I'd known what I know now back at the beginning, and I think there's a constant learning, isn't there? And I would just urge you to, I wish you all the luck with all of this. I think it's a really important point of change in approach, and the sort of joining up at every level feels absolutely the right thing to do. And I really, really support it. But I think if you keep in mind, as Stephen says, you know, we're here purely for the patients and the population, and encourage the staff, release them in order to be great, because they will innovate and they will make those changes and help them be happy, as we talked about earlier. So all the best with all of that, and we're not quite gone yet, are we? But we're on our way. We're on our way. Thank you.
On behalf of us all, you know, thank you both very much. And look, and you're not going to escape forever. You know very well that you'll be back somehow in the NHS before too long, I'm sure, in some way. Good. Any other business from anyone? Good. Thank you.
Thank you. Thank you.